Can you use GLP-1 agonists to treat autoimmune conditions? Hello, this is Dr. Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine, expert in rheumatology and regenerative medicine. Question I, on occasion, get is whether you can use some of the newer GLP-1 agonist medications to treat autoimmune conditions. Let's break this down because there's a lot involved. First off, the GLP-1 agonists are a newer, for the last several years, mechanism of treatment that treats both diabetes and weight loss. It works by helping the body to better utilize and metabolize blood sugar once it's in the bloodstream, and also reduces hunger cravings and reduce the amount of food that a person wants to eat. So it helps and is approved for both diabetes and weight loss, and frankly is really revolutionary for both of those conditions. Autoimmune conditions are conditions like rheumatoid arthritis, lupus, Sjogren's, psoriatic arthritis, various others, where your body's immune system that is meant to protect you from bacteria and viruses is now miscommunicating and attacking your own body. So the traditional treatment for autoimmune conditions is to utilize medications that help to pull back your immune system, basically immunosuppressants. There is this growing understanding that your metabolic health may be connected with your inflammation. So we know in psoriasis and psoriatic arthritis, in people that are overweight, if they lose weight, they will not only help to reduce the disease activity from their psoriasis and their psoriatic arthritis, they also respond better to the immunosuppressant medications that they receive. That creates this link that, okay, you can improve your metabolic health by losing weight in this case, and that it seems to make an impact in terms of your inflammation, your autoimmune condition as well. So then the next question is, can GLP-1 agonists that work dramatically well for losing weight and for metabolic health, can that be utilized in autoimmune conditions? A lot of rheumatologists are interested in this. A lot of patients are interested in this concept. So we have some data in this. This is very early. Recently, a study came out that showed that in psoriasis and psoriatic arthritis patients who are overweight, that if they combined a GLP-1 agonist with an anti-IL-17 medication that is traditionally used for psoriasis and psoriatic arthritis, what they found is that in those folks who took that combination, not only did they lose weight, as you would expect with a GLP-1 agonist, but they also had better results for their psoriasis and psoriatic arthritis as compared to if they were only taking their immunosuppressant medication. So again, this connection between metabolic health and autoimmune and inflammation health is being buttressed or further supported. So, and keep in mind, right now, this has only been studied or more fully evaluated in psoriasis and psoriatic arthritis. We don't have that same level of evidence or data in other autoimmune conditions. So then the next question is, can you utilize a GLP-1 agonist as a primary treatment in, let's say, psoriatic arthritis or psoriasis? We don't have any data on that at this point in any large-scale trials. There may be anecdotal results that suggest that can be useful, but we don't have anything that compares, hey, here's a group of patients who are taking GLP-1 agonists and are losing weight, and here's a group of people who are taking their traditional immunosuppressants, and let's see how they compare. In addition, we don't have any data that looks at, well, how about those patients that don't need to lose weight? What happens if you're just working on their metabolic health and then comparing that to taking immunosuppressants as well? So we don't really have that as a comparison right now. In psoriatic arthritis and in other autoimmune conditions, we don't have enough right now to say you can utilize a GLP-1 agonist in place of a person's immunosuppressants. And that's for not only psoriasis, psoriatic arthritis, but definitely for other autoimmune conditions where we have even less data. So for those patients who are still interested in this concept, here's how I would think about it. if you have a condition that is moderate to high risk for progression, then you really should be utilizing the treatments that we know work and that have been studied for the last few decades. And that is the traditional immunosuppressants that are utilized. And the reason why is because if you have a moderate to high risk of progression over the next year, the risk of not taking standard treatment is fairly high. And that means when we talk about progression, we're talking, in the case of inflammatory arthritis, we're talking about damage in the joints, leading to more long-standing disability, pain, and sort of irreversible changes. That even if you can get the inflammation under control in the future, there's still chronic damage then. In folks that are moderate to high risk, I would be very cautious about utilizing something that in theory makes sense, but doesn't have a lot of really proven scientific evidence to say that it makes sense to do that. I would still stick with what is sort of proven and tried and true. What about if you're at low risk for progression? So number one, how do we define low risk for progression? Well, we look at how much inflammation do you have right now. For example, in rheumatoid arthritis patients, we know that there are certain ultrasound findings in the hands and wrists that, if present, show that you're at high risk or moderate to high risk for progression, meaning more damage in the joints over the next year. If you don't have those findings, then it may be reasonable to consider an alternative treatment. Caveat here is you should be closely followed by your rheumatologist, because if your condition, even if you're low risk at one point, your condition can evolve over time. 6 months later, you may now have dramatically higher inflammation and now a higher risk for progression. So in those patients who are at low risk for progression, if they're trying something like a GLP-1 agonist that is not fully proven, but kind of intellectually makes sense, I think that is okay to try, but with very close supervision by your rheumatologist so that you have an off-ramp to get back onto traditional treatment if needed, and so that you're not falling off the cliff in terms of disease activity. Then the next question that comes up is, well, what about utilizing a low dose, a microdose, if you will? It's an interesting concept. When you think about the dosing that is traditionally utilized for GLP-1 agonists, it's based on what you need to control diabetes, a condition where blood sugar is wildly out of control, and in people for weight loss where they're trying to lose 15 to 20% of their body weight, because that's what GLP-1 agonists on average can do. So when you're talking about an autoimmune condition, if you're not trying to achieve those same kind of results in terms of weight loss or blood sugar control, does it make sense to try a microdose? Maybe. Again, we're talking about things that are not fully studied yet, but it's a attractive, interesting idea. But as with all these things, I think the key is if you're trying something, make sure you understand what is standard of care. Make sure you understand what are the risks. If you're not going through standard of care, make sure you're working with physicians who know how to handle this kind of situation properly and know how to manage your condition as it evolves over time.